we're going to discuss about ABG. All right. So this is mainly about. It's mainly going to cater to maybe UGs or even myself. I'm a postgraduate, so it's going to cater to UGs who are interested about the topic, who are interested about interpreting ABGs, and who want to know uh, how we interpret those blood gas and you know several clinical applications of the same. All right, so it's a very interesting topic. So we're going to start with and we're going to deal only with practical things and theoretical, but which cannot be really separated from practical as well. So starting with the topic blood gas analysis. So in blood gas, we're going to have some measured values. All right, the values which are measured by the analyzer. All right, that is nothing but measured values, which are the parameters, most parameters the ABG has. All right, like pH, PCO2, PO2, and these measured values are used to calculate the calculated values. Which are the calculated values? The calculated values are bicarb. The calculated values are can be alveolar arterial gradient. Okay, it could be the O2 concentration. So these are the calculated values. All right, and there are the entered values. So the values we have to enter, the machine can't know by itself. For example, the FiO2, we have to enter the FiO2, we have to enter the hemoglobin, right? Hemoglobin concentration. So all these are the different things we have to know first: measured value, calculated values, entered values. All right, so next comes something like so a few basic stuff first. pH. What is pH? pH is nothing but negative logarithm of H plus ions, isn't it? And what is a normal pH of our blood? 7.36 to 7.44. So whenever you do this, always remember there are several things to know, but always remember PCO2 normal is 36 to 44. All right, and your pH. So this you can remember 36 to 44, and bicarb. How much is bicarb normal range? It is 22 to 26. So average you can remember this as 40. You can remember this as 24. All right. So coming back to pH. So pH is nothing but negative logarithm. So the normal pH is this 7.36, 7.44. Now we know that if and remember we have a formula which is the H plus is 24 into PCO2 by bicarbonate. 24. Remember this, and this we have studied in chemistry. It is nothing but the Henderson-Hasselbalch equation. All right. So this is nothing but the Henderson-Hasselbalch equation. So why this is important? What is the clinical application of it? We are going to see in our further thing. All right, we're going to see further in this video itself. Now, so as you can see, this particular formula, H plus is calculated by nothing but a balance between, or it is directly proportional to the ratio of PCO2 and bicarb. All right. So the more the hydrogen ions, so what is the normal concentration of the hydrogen ions? 35 to 45, and normal pH is 7.3 to 7.4. All right. So that is what it is. Yeah. So the next thing is the normal ranges. Normal ranges, I already told you, right? pH is normal. pH normal range is 7.36, 7.44, and so on. Bicarb also normal range. I told you 20 to 26. Now, what are the steps of analysis of ABG? What are the basic steps in analyzing the ABG? So the first step is, which most of us don't do, is to verify the internal consistency. Very important, verifying the internal consistency, and this is where the concentration of H plus equation comes into use. Now the second thing is nothing but determining the pH. All right. Third is recognizing the primary acid base disorder. Right, that's the third step, recognizing the primary acid base disorder. Now, once you have, first of all, you have just made sure that the ABG is not displaying, I mean, it is a correct and accurate, I mean, it is the consistency is good. It's not some nonsense, okay? Second is, we have to determine the pH. We have to say whether it's acidosis or alkalosis, right? Acidosis or alkalosis. Third is, what is the primary disorder? Is it metabolic or respiratory? All right. So coming to fourth. Fourth is, now once we have calculated the primary disorder, we have to calculate the compensation as well. We have to calculate compensation. We have to calculate the compensation. Before all this, you can add that we have to see hypoxemia also. Hypoxemia. So that is one of the first things that we do. We look at the PO2. All right, we look at the PO2 to see the hypoxemia rather. All right, so that is the different part of the blood gas, but right now we are dealing mainly with the pH. This also I'm going to talk in detail about the hypoxemia part of it and the AA gradient and everything. So fourth is calculate compensation. Fifth is going to be identifying the second disorder. The second disorder, if present, and if present, how much of it, how much is present, the extent of the secondary disorder, right? Basically the magnitude, how much is it present. Now sixth is going to be, if there is metabolic acidosis, if there is metabolic acidosis, we have to see the anion gap. All right, anion gap. So there are two types of metabolic acidosis, based on the anion gap, whether it's normal anion gap metabolic acidosis or high anion gap metabolic acidosis. The most important is whether it is high anion gap. If it is high anion gap, then we have to calculate the delta gap, to look at if there is any coexistent metabolic disorder. All right. And we also, if you're suspecting some toxin related cause of high anion gap metabolic acidosis, then we have to calculate the osmolar gap as well. Osmolar gap, identify toxin related. So osmolar gap to identify toxin related cause of hagma. All right. If we are talking about normal anion gap, then also we have to calculate. Then first, most importantly, we have to calculate urinary anion gap. Remember, and we are going to have to calculate the osmolar gap here as well. All right. So that is what is the main thing. What do you mean by a coexistent metabolic disorder along with high anion gap metabolic acidosis? And why do we calculate urinary anion gap and osmolar gap in case of normal anion gap metabolic acidosis as well? Because in high anion gap, we calculate the osmolar gap in order to identify a toxin related cause of high anion gap. Why is there a need of calculating urinary anion gap in case of normal anion gap and osmolar gap in case of normal anion gap metabolic acidosis also? Can you tell me? I have messed this whole thing up, but that is for a reason. I just want to tell you a few things. I know this is all very looking very clumsy and everything, but just bear with me. It's going to be clear in a while. So if we talk only about so first of all, what is anion gap? Anion gap is nothing but, I hope you know what is anion gap. Anion gap is nothing but it is representative of the unmeasured anions. So there are two formulas of calculating anion gap. That is, one is sodium plus potassium minus fluoride plus bicarbonate. It is measured cations minus measured anions. So it is a more comprehensive method. However, what we generally do in practice is sodium is the only cation which is used minus fluoride plus bicarbonate. All right. So if that is a formula which is used, and you can ask why is potassium taken out, because it's one of the measured cations. It is taken out because of two reasons primarily. One is that it makes the formula simplified and easier for us to calculate. And second, more important thing is that potassium plays a very minimal role, in the concentration of cations, because it has a very low concentration in our serum plasma. In our plasma, it has a very low concentration, so it doesn't very significantly contribute to the thing. So okay, so that is anion gap. So we'll get to anion gap and we'll come back again. A brief discussion of anion gap, which we'll just say with you. So this is the more comprehensive one, but this is what is used. All right. Now, anion gap, as we know, is nothing but representative of the unmeasured anions. So when we say this will be very interesting and relevant if you think about what is high anion gap metabolic acidosis. So high anion gap means nothing but increase in the unmeasured anions, right? High anion gap means increased high unmeasured cations. Sorry, unmeasured anions. So what are those unmeasured anions? They could be those high anion gap metabolic acidosis means increased unmeasured anions. Those anions can be lactate, ketones, or any toxins that can be there. High means more than 12. Normal target range is what? 8 to 12. If potassium is excluded, and another reason why we don't include it is it will change the reference range for a normal anion gap will be between 12 to 16 if we include potassium. So we simplify it to the one without potassium. So here I've included potassium concentration relatively low, so minimal contribution, and also to simplify the equation in practical settings. So high anion gap metabolic acidosis, that there's a very, very popular mnemonic existing for high anion gap metabolic acidosis. That is nothing but mud piles, all right. So many of the letters of this mnemonic is nothing but toxins. If you look up at this this is methanol, a toxin. So methanol, then you have propylene glycol, then ethylene glycol, then we have a couple of drugs, that is one is INH, one is salicylate, all right, INH salicylate. These can also be considered along with those toxins, and drugs, toxins comes in the same family. The other two things are, if you see, diabetic ketoacidosis, that is ketones and lactic acid, all right, ketones, lactic acid, diabetic ketoacidosis, lactic acid, and even uremia. Even uremia can lead to high anion gap metabolic acidosis. Now, since we have given a minute to high anion gap, let's just give an overview. Later we're going to go in a little more detail. So okay, normal anion gap is nothing but, what is the normal anion gap? It is 8 to 12. As we know, it is 8 to 12. Now normal anion gap is also known as, what is it also known as? It's also known as hyperchloremic metabolic acidosis. So these are all metabolic acidosis, right? Metabolic acidosis, there are two kinds: high anion gap, normal anion gap, metabolic acidosis. So why is this called hyperchloremic? Because the loss of bicarbonate, as if you can see here, the loss of bicarbonate is compensated with or is balanced by chloride retention, right? That is why there is more chloride in the body. That is why it is called hyperchloremic metabolic acidosis. Now, what are the examples? Examples could be many. So very common examples are, one is diarrhea, all right? Diarrhea, vomiting, these are all the causes of this. Then the other cause could be RTA, renal tubular acidosis, early CKD. Remember, early CKD or early chronic kidney disease is the cause of normal anion gap metabolic acidosis, although uremia, which are the late stages of maybe, AKI or late stages of kidney disease, they can lead to high anion gap metabolic acidosis, all right? So, so if we ask that toxins, right? Toxins, we have heard more in relation to high anion gap metabolic acidosis, but I want you to know that it is not only high anion gap, but also normal anion gap metabolic acidosis causes are toxins. Now, which are those toxins? Can we differentiate? Toxins causing high anion gap is, as we know, it is propylene glycol and methylene glycol, salicylates, lactates, ketones, all that we discussed in the mud piles mnemonic. And what about normal anion gap metabolic acidosis? Now, this is very important. Remember, we can't really rule out normal anion gap metabolic acidosis in case of toxins, because there are some toxins which cause normal anion gap metabolic acidosis, which are ammonium chloride, acetazolamide, cholestyramine, and toluene. All right. So yeah, toxins can also cause. Toxins can cause. So toxins can cause. Toxins can cause. There you go. That's a mnemonic as well for normal anion gap metabolic acidosis. All right. So you'll remember this. See how to verify the internal consistency of the ABG. Okay. So suppose we have this ABG right here, pH 7.32, PCO 240, and bicarb of 20. So if you first see this and we want to verify its internal consistency, so we had seen one formula at the very beginning, that is this formula, which is also called the Henderson-Hasselbalch equation, isn't it? I had mentioned this at the beginning. So this formula I told will be used to verify the internal consistency, which is the very first step in ABG interpretation. So suppose we have this value right here. How can we verify it? Now, So we'll use this. We'll use this to calculate the hydrogen, the concentration of the hydrogen ion, which is nothing but, we'll see, we'll do this right here. In this case, the hydrogen ion would be nothing but 24 multiplied by PCO2, which is 40, and bicarb, which is 20. So this will become 48. Okay. But we don't have the value of H plus here, but we have the pH. Now it turns out that there's a formula which says the last two digits, I mean the 7 point, whatever two digits come after the decimal, last two digits of pH can be calculated by using this formula, 80 minus the concentration of hydrogen ions, right? So roughly this is the formula which is used to, so will be equal to, so we'll change this, H plus equals to 80 minus two last digits of pH, right? So last two digits of pH is equal to 80 minus 48. So the last two digits of pH is equal to 80 minus H plus ions, which is nothing but 32. Now it should be 7.32. Now does this match with this? This value, does this match with this? Yes, it does match. It does match with 7.32. So this is an internally consistent value. I mean, this is the internal consistency of this is completely verified. Now, next thing we're going to see is if an ABG is consistent, then we can go ahead. If the ABG is not consistent, what are the reasons why it's not consistent? We'll just take a second in just knowing this. See, there could be problems in our technique. There could be problems in the storage. There could be problems in the ABG machine. There could be problems with the patient. So if we talk about the ABG machine, the problems could be electrolyte. I mean, the electrolyte within the ABG. Malfunction of those electrolytes can be there, which can lead to wrong ABG values. And then the calibration may not be accurate in the ABG machine. That is why ABG machine needs to be recalibrated in regular periods, in regular intervals. All right, so that is the ABG machine. The second thing is about the patients. Sometimes, in cases of severe lactic acidosis or ketoacidosis, the ABG is not proper. Okay, that is the second thing. Third is, I mean, the verify. No, it's not that it's not proper. The internal consistency may seem inaccurate. So the patient, and the other two is the problem with the technique or problem with the storage. That is problem with us, the ones who are taking the ABG or storing the ABG sample. So in the technique, there could be two issues of improper technique. One is while taking the ABG, there is venous admixture. Second is there is air contamination. So air contamination means that oxygen will come from air to the sample. PO2 will be falsely high, or PCO2 will diffuse from the blood to the air. PCO2 will be falsely low. These are the problems in technique. And storage, if we do an improper storage, RBC metabolism will occur. O2 is consumed, CO2 is produced. So falsely decreased O2 and high PCO2. Okay, so these are roughly okay. So if it is not showing to be consistent, what we have to do is we have to reanalyze the sample, one thing, or we have to redo the calibration, or we have to verify ourselves the calibration parameters of the ABG machine. All right, yeah. So now coming to the next part of it. So talking about the next part, we'll just see the basics of primary disorder. So how do we say that? What is a primary disorder? How do we say that? So one of the first things, right, which I discussed, a little bit in the beginning, but now I'm going to discuss in a little bit of detail. So what we see is the pH, and the direction of the change of, pH we see, or we see, and we see the PCO2 and the bicarb. All right. So PCO2 is a respiratory component, bicarb is a metabolic component. So in respiratory disorder, we see seesaw or opposite change of pH and the metabolic parameter, that is the bicarb. The respiratory parameter, that is PCO2. In respiratory disorder, we look at the pH and the PCO2. And in metabolic disorder, there is an elevator effect. All right, elevator effect. That is, they both move in the same direction. All right. So you got it. If you want examples, suppose pH is 7.3, which is a low pH. Now we look at the bicarb. Suppose the bicarb is high. Maybe the bicarb is 30. And the PCO2 is maybe 44. So see, this is acidosis, right? First we look at the pH, it is acidosis. Then which value is supporting the pH change? The acidosis. It is the PCO2 which is supporting the, so the primary disturbance is respiratory acidosis. isn't it? So similar way, if the pH is 7.3 and you see the bicarb to be 12 and you see PCO2 to be maybe 36, all right? So here we can see PCO2 is normal, but the bicarb is low, that is 12. So pH is the change in pH, that is the acidosis is going to the decrease in bicarb is making sense of acidosis. So in this case, it will be the primary disorder will be metabolic acidosis, isn't it? So yeah, that's the one thing. Second thing is so I hope you understood this concept of seesaw and elevator, right? So in respiratory disorders, the pH will move with the carbon opposite to the carbon dioxide. If acidosis is there, that is pH goes low, carbon dioxide will be high. So high carbon dioxide will be the cause of decreased pH. If the pH goes high, that means that there is low carbon dioxide. That is respiratory alkalosis. That is seesaw. In case of metabolic disorders, if metabolic acidosis is there, pH is low, then bicarb will also be low. Low bicarb will be the cause of acidosis in metabolic acidosis. High bicarb will be the cause of metabolic alkalosis. Okay, in the similar effect, elevator effect. Same direction, same direction. This is opposite direction or opposite directions. pH, PCO2, pH, HCO3. Right, now since we have talked about these two, it's time to talk about the compensation. Okay, so this is also a very, very interesting topic. Compensation. What is this compensation concept? So once you master this part of it, we'll get to compensation. So what is compensation? Compensation means in respiratory acidosis, there will be metabolic compensation. And in metabolic acidosis, there will be respiratory compensation. In metabolic disorder, there will be respiratory compensation. So if we talk about, first we'll get to respiratory disorders and the metabolic compensation for the same. All right. So what do we see about it? The first thing we're going to see is in respiratory acidosis. See, what have I mentioned here? In case of respiratory acidosis, you just have to remember 1:4. In case of respiratory alkalosis, you have to remember 2:4. All right, 2:4, and these are for acute and chronic. So how do you understand this? This 1 and 4 in this 1:4. 1:4 is just a way of remembering, okay? So this 1 and 4 is nothing but the change in bicarb for every 10 mm change in PCO2 above 40. Delta means change, all right? So for every 10 mm change in PCO2 above 40, the change in bicarb will be 1 or change in bicarb will be 4 in acute and chronic respectively. What about respiratory alkalosis? So if you want an example, before moving to respiratory alkalosis, we'll see respiratory acidosis. So suppose there is respiratory acidosis. All right. So suppose pH is 7.2, PCO2 is 50. Okay. And so what do you expect? What should be the compensation? So this is nothing but respiratory acidosis, isn't it? So what do you expect the bicarb concentration to be if fully compensated? Okay. What should be the bicarb concentration? Bicarb concentration should be, so for every, how much change is there from 40? There is 10 change. So for every 10 change, there should be 1 change if it is acute respiratory acidosis. In case of acute, since it is only 10, the bicarb should decrease by 1. The bicarb should increase by 1, because we want, in case of respiratory acidosis, we want compensatory metabolic alkalosis, right? So bicarb has to increase in order to take the pH high. So how much increase will be there? There will be only 1 decrease. Okay. But if it was chronic, then for every 10 change, that is here, there is a 10 increase, that is 10 change. And so therefore, if it was a chronic respiratory acidosis, the change would be 4. Okay. So in case of acute, it would be 25. In case of, it would be 28. So if bicarb was 25 and in case of acute respiratory acidosis, it would be a fully compensated. Okay. So this is an example of this. Now, what about respiratory alkalosis? Respiratory alkalosis may, similarly, the ratio is 2:4. So in case of if you want to know about respiratory alkalosis, the change is 2:4. Suppose if we talk about respiratory alkalosis. So if we talk about respiratory alkalosis, again, we have the ratio as 2:4 for every 10 change in PCO2. Okay, this is acute, this is chronic respiratory alkalosis. Suppose we take a pH. Suppose we take a pH of 7.1, 7.5, and we take a PCO2 of 10. So this is nothing but alkalosis. Change from 40 is how much? 30. So change in PCO2 is 30. So for every 10 change, the change in bicarb would be 2. Right. So in this case, since it is respiratory alkalosis, there must be compensatory metabolic acidosis. Compensatory metabolic acidosis. How does metabolic acidosis happen? When bicarb falls, right? When bicarb falls. So bicarb falls. Bicarb fall will be how much? 2:4. So see, this is 30. For 10, if there is 2 fall, for 30 there will be 6 fall. For 10, if there is 4 fall, for 30 there will be 4 into 3, that is 12 fall. Okay, in bicarb. So what is the normal bicarb? Normal bicarb is 24. 24 minus 6 is 18. And 24 minus 12 is 12. So the bicarb values would be this in acute respiratory alkalosis, fully compensated acute respiratory alkalosis, and fully compensated chronic respiratory alkalosis, and 12 in fully compensated chronic respiratory alkalosis. So got it, no? This is the basic thing. Took a lot of time, but I hope you understood what I'm talking about. Yeah. Thank you for your patience.